I would like to start the day with introducing our first session, which is the rare brain diseases, and would love to introduce our moderator for today, Dr. Arif Khan, CEO and founder, Neuropedia Children's Neuroscience Center, Director and Consultant Pediatric Neurologist, Burjeel Hospital, Associate Professor of Pediatric Neurology, Mohammed bin Rashid University of Medicine and Health Sciences, Dubai. Dr. Arif Khan.
Good morning, everyone. Sunday morning, and we have a few in attendance, so that's encouraging. Pediatric neurology session, we've come a long way, starting from just making diagnosis, not knowing the pathogenesis, and giving prognosis based on that to patients 2 decades ago, to now almost talking about treatment and cure with our patients in this field, and not just knocking on the holy grail door, but actually entering it in many conditions. And our first speaker here, Dr. Vivek Mundada, a good friend and a colleague who is a consultant pediatric neurologist at Medcare Women and Children's Hospital, also covering a lot of Aster DM healthcare facilities, whose interest is neuromuscular diseases, and he's breaking barriers in neuromuscular treatments and gene therapies in this region. So without any further ado, let me call upon Dr. Vivek Mundada for his talk on gene therapy for spinal muscular atrophy.
Thank you very much. Thanks for the kind introduction, and thanks to the organizer for giving this opportunity. As Dr. Arif has just mentioned, we're living in exciting times where new things are coming up. We're changing the barriers, we're changing the course of what it used to be a life-limiting conditions and dreadful conditions. And one of them is spinal muscular atrophy. Those of you who were yesterday, I can see some familiar faces. We talked about SMA, so I'm not going to talk much in detail. Just rush through those things. So, SMA is a monogenic condition. It's caused by the mutation in SMN1 gene. I'm sorry, the resolution is not very clear there, but the top one, it shows that a normal cell with a normal SMN1 gene will produce a functional protein. As a result of that, the muscle architecture and the muscle strength is preserved. But if you have no SMN1, no functional protein is produced, and the muscle starts getting atrophied, and that's how the name is. And it's because the disease affects the motor neuron cells in the spinal cord, so that's why spinal muscular atrophy. And the bottom thing is also emphasizing on something called SMN2, which is like a backup gene we all have. But the problem is it just produces a very small amount of functional protein, or rarely any functional protein. However, those with the mutation in SMN1 rely on this backup copy only. So you can imagine more the number of SMN2, the stable is the child. And that's how the phenotype is classified in SMA. And that's the SMA disease there. So as a result of this mutation, if there is no functional protein, the muscles are weak, but it's a multi-system disorder as we know of, and the muscles of the breathing, the intercostal muscles, the swallow, the digestion, everything gets affected. And these are just the clinical signs to emphasize. Muscle weakness, nutrition problem, absence or decreased reflex, the respiratory issues, tongue fasciculation, orthopedic problem, and any child who presents as a floppy infant, early in their life, this is something we need to really think of. And it's not that uncommon, and there's a lot of raised awareness these days through the social media, especially the parents group, and now that therapeutic options are available. So the incidence is said to be 1 in 10,000 by birth, but what is striking is it's the second most common fatal autosomal recessive disorder after cystic fibrosis worldwide. The typing is done according to the phenotype. For example, type 1 is where the infant doesn't ever achieve sitting, whereas the type 2, it can sit. Type 3, they can walk and become ambulatory. Type 4 is seen in adults, but in population because they present quite late. So most of the cases, more than 2/3 of the cases of all SMA are type 1. And as you can imagine, these infants never achieve sitting in their life if untreated. And Because it's a progressive condition, the motor neuron cells are dying with time because of the lack of gene, and the time is more precious in these children. So the onset in type 1 is within a few weeks or within a few months. The children present with being floppy, not achieving head control or losing the motor skills. And what is unfortunate in these children is because it's a progressive condition, your respiratory muscles, the swallow muscles start getting affected, and almost every child untreated will be needing the invasive ventilation or support with the feeding like gastrostomy and the NG-tube. And it's very rare for these children to even see their second birthday. That's common mortalities because of these coexisting problems. And that's what we thought when we talked about the typing of the SMN, which is more of a based on the clinical presentation, type 1, type 2, type 3, and type 4, I just discussed, but there's a onset. And so, you have the time to treat these types, but the most striking is type 1, and this is a major chunk of SMA patients. The diagnostic delay is very common because, missing the diagnosis, as I was just saying, time is precious in these children. If you lose time in diagnosis itself, we're losing precious time. And we're emphasizing on how, this is one of the studies which shows the average time between the symptom onset and the diagnosis. So if you can see, the child is walking and very mild symptoms, it's common to have this kind of delay, and that is in months that we're talking about. So if I have to choose a best time to treat these children, that's the window when this is before they start declining, and that's the best time because, that's later in the course of the disease, there is hardly any usefulness of the treatment because you have to really weigh the pros and cons, the ethical kind of dilemma is there, the productivity of treating these children. So probably you can treat in this next third of the phase, but later when they start declining and there's a lot of comorbidities, it's really futile to treat these children. And that's what there are studies of all the drugs that use in Aster, even the Onasem regime or the gene therapy have shown us, and our clinical experience is the same, that earlier you treat the child, if you catch them pre-symptomatic, they hardly develop any symptoms, and that's the emphasis on early diagnosis and early treating these children, and that's probably the best window to do that. We have, these things has probably not changed even with the introduction of the novel therapies, the disease-modifying therapy, because what our experience is, this, I call it as a milestone in the journey of the patient. So your treatment is just a milestone, but your multidisciplinary care continues before the treatment, after the diagnosis, and even after the treatment. So that these drugs are not substitute to multidisciplinary treatment, and we have certain case studies to prove that as well. So it's very important that we have this 2018 standard of care for SMA, which still stands kind of true, although things are evolving, things are changed, maybe there's a new version, but what it shows is the emphasis on multi-system management, including respiratory, digestive, orthopedic, spine, nutrition, and somewhere there is a medication now sitting in this MDT approach. So previously the patient had to go to all these specialists to seek the care, but now the emphasis is there's some stake on us, the onus is on us to arrange that care for the patient, and that's very important aspect. We have used, because how do we assess the progress objectively? And there are many scales available which we call functional motor scales. So depending on the age, we use that shopping tent, there's a baby scale, there's a Hammersmith infant neurological scale. In the older children, we use Hammersmith functional motor scales. For the arms, we use RULM scales and so on. And this is kind of a good measure to say how well the child is doing, and we can monitor. And these scales have been used in the research practice as well. What are the treatment strategies? So we know that it's a monogenic condition, so the target is different. So the thought is, what if, so SMA-dependent therapies, so what if we modify the SMN2 because the body lies on backup gene. So the only difference is there is one exon which is non-functional, not included when producing the mRNA. What if we include that and make a full functional protein by doing something to SMN2? and some drugs like risdiplam, Spinraza are targeting the SMN2, whereas the other strategy is you just replace simply what is missing. So SMN1 is missing, so just introduce that in the body and that will start producing the gene. So that's the diagram in the first instance where your gene is introduced in the vector, you just give in the body and it will start producing, it will just get the assembly of the cell and start producing mRNA and the protein. Whereas as I said, you can also target SMN2. I'm sorry, this is very poor resolution, but that's the right side is SMN2. So what is gene therapy? So European Medicine Agency gene therapy definition is a gene is a DNA segment that contributes to the phenotype or the function. So it has to have that function which is useful to the body, and the gene that leads to therapeutic, prophylactic, or diagnostic effect. And a recombinant gene is a stretch of DNA that is created in the laboratory, bringing to the DNA from the different sources, and this is what the DNA we are using to introduce in the index cases. So the strategies can be, we don't have a gene, let's just add the gene. So that is like the gene replacement. And or if you're deficient, you can add the gene. Okay. Other strategy can be, something causing a faulty protein. Then you can correct that and start manufacturing the productive protein. Or something is not produced, you can change the structure of the gene so that that particular gene will start producing the functional protein. And the third strategy is to just take the faulty gene, alter that, and introduce it back in the body. So gene, altering the genome itself can be a strategy. So what we're doing here is a gene which is sent in the body, an external kind of gene. So we need some vector to introduce in the body. So the vector is what we are using in this condition is AAV9. So there is a promoter because the gene has to have instruction to start the protein production. There is this transgene, which is the gene of the interest, and there has to be a terminal signal. So the gene has to have the signal where to stop producing the protein, because that kind of gives the enough instruction to start. So there is a promoter, transgene, and terminal signal, and that's the whole assembly is fitted into the AAV9, and it's given as IV to the children. So onasemnogene is the name for the gene therapy for SMA. It is given for 5q, which is the typing of SMA I was talking about. In UAE, we have a license to give this to anybody with up to 3 copies of SMN2 and up to 21 kg. Some countries use age as the criteria. We are using weight as the criteria. And as you can imagine, it's very difficult to achieve that kind of weight in type 1 at least. But as you grow older, the complexity is more and more, and you have to be very selective with the criteria. It's given as a single dose IV over 60 minutes. So just simply, we know that individuals with SMA don't have SMN1 gene, and with onasemnogene parvovec, we're infusing that SMN1, and it starts producing the functional SMN protein eventually. And I just showed you a brief video how that works.
Gene replacement has been 150 years in the making. Over the last 20 years, there is more scientific research on how gene replacement therapy opening new possibilities of treatment of serious and life-threatening diseases. In more general terms, signal faulty or missing gene or gene pair can cause a problem in the body's ability to make the gene protein. By replacing the faulty or missing gene with functional gene material, or transgene, gene replacement therapy can enable the cells to make the required protein correctly.
Okay, so whatever. So a little bit forward. Yeah. So this is a vector we are using in which the transgene is introduced. And there are different types of viruses have been used as the vectors.
They allow efficient, stable, and sustained gene expression avoid replication and toxicity, most viral genes are removed and replaced with the desired transgene. Adeno-associated viruses, or AAVs, have emerged as favourable vectors for GRT, as they have a good safety profile. There are several AAV variants that target different tissues. AAV9 can be administered through IV injection, using its natural ability to bypass the blood-brain barrier to reach the central nervous system. AAV9 protects the transgene as it enters target cells. Once inside, the AAV vector uncoats, releasing the transgene. The transgene exists as a stable unit of DNA. Once in place, the transgene employs the cell's innate machinery to activate gene expression. The transgene is designed to include a promoter to ensure rapid and sustained gene expression, introducing the possibility for long-term efficacy. With continuous gene expression and stable protein production, AAV-mediated gene replacement therapy has the potential to treat a range of monogenic diseases. Advancements in gene replacement therapy continue to bring hope to communities of patients, families, and physicians around the world.
Yeah, fascinating. So there have been various trials to try the one assembly gene before it was FDA approved, and there are still long-term follow-up studies are ongoing. So again, the target of the population is those with type 1 or those with more copies of SMN2. And now the interest is again, if you know nusinersen, we give intrathecal, so it's going nearer to the motor neuron cells because we give this as an IV. So we just want to know what if we give onasemnogene as intrathecal, and time will tell. So the strong trial is ongoing at the moment, and we're also trying this therapy for older children. So as I said, there is a limit to whom we're giving. So what if we give to the more stable but adult or adolescent? So I'm not going to go into more details, but what the briefing about various trial is this provides improvement in the motor function, respiratory function, feeding function, which is not seen in the natural course. Because as I said, these children will deteriorate, they will never gain any new milestone, or there will be no any improvement. Intrathecal, we just talked about, long-term follow-up of course is needed. So far we have data of over 6 years now with its efficacy, and overall the profile is favorable. In our experience, we have started this program back in 2020 when there was a patient support program was in place, and we have experience of over 50 cases now with variable age and variable weight. But as you can see, no child has reached to that 21 kg. I think the highest I have given is around 15 or 16 kg. So just briefly, because in the interest of time, this child was one of my first cases we infused in November 2020, type 1 case, and mother has made a nice video actually. The first video is playing, but you can see the child is hardly moving. There was just distal movement with anti-gravity ankle, and the distal joints of the limbs. And this is a bit lengthy video because mother has given me that timeline. But what I wanted to show is following that up, we have seen improvement in the functional motor scales. And not only that, if you see the child is very stably sitting, you don't achieve that in type 1. And after 2 years, by invariably, the child will be needing assisted ventilation, tracheostomy and all. This was just unfortunately the recent choking episode, but the child was feeling well. We're still assessing the swallow and all. But the motor scales have significantly improved. As I said, she's able to lift her shoulder, the trunk control is better, and she's a chatterbox. And she was never ventilated, as I said. There's less requirement of hospital admission, less requirement of the antibiotics, especially for the respiratory things. Again, she was dosed in November 20. Type 1 case, the good thing was she was very kind of better in the sense when we infused. And this is the emphasis, you give early somebody and they tend to do better. And this is the recent, so this is just in her infancy, but if you see now, she's standing with support. We have given the walker to her. She's able to walk with support. And the parents are really good, because I said that multidisciplinary care is very, very important even after what you give, because if you neglect them, the previous child like presented with choking episode, if you don't screen for swallow and all, but that's the difference. I just want to say that she's in a physiotherapy session, much better drug control. As I said, she's even walking with support, and hopefully we have support in few months, which was never possible in type 1. Forget about standing or walking, they don't even sit anytime. So she's trying to stand there. And this one also never ventilated, feeding orally, and that's how we can change the course. So I was telling about the motor scales, and this is just a cumulative assessment of our the motor scales, how significantly they improve. This one I just want to bring it up because if you see these lines are nearly running parallel, which means the better is the score earlier, these children tend to do better, and so the complexity we have to deal very early. So screening these children, identifying the problems and dealing them even before they cause the low moment is very, very important in the children. We have cases with respiratory kind of those who are needing invasive ventilation. So nearly half and half very invasive and non-invasive ventilation. Very few cases just continuously breathing. But we have the data. We are one of the few centers who are doing the gene therapy for these patients as well. Of course, we have a strict criteria for selection which patient to use for gene therapy. But overall, what we have seen is there is a decreased airway secretion after the gene therapy. There is satisfactory chest expansion, resolved bell-shaped chest, resolved paradoxical breathing. There is a strong cough in the children. And the top graph is very squeezed and there's less resolution, but what it shows is the time of ventilation. So our criteria is that they should be at least having 8 hours of ventilation before receiving the gene therapy. And many of them at least have regained that or have improved, apart from that one child who was admitted with aspiration that I was showing. But eventually has got better. So the long-term follow-up is important, including all the members like pulmonologists, gastroenterologists, spine surgeons and all. So respiratory outcome, what we have seen is increased time of ventilator, reduced upper airway secretions, decreased need of antibiotic and hospital admission, which is quite significant in these cases. I'll probably skip this case. It was a very complex case, but I just wanted to emphasize the importance of multidisciplinary care in the journey of the patient and how that can change the outcome. So just not the drug, it's a team which is associated with you. So take-home message is early treatment is important, and that's why we're talking about newborn screening these days. Many countries are coming up with that idea. For example, Kuwait is even coming up with premarital screening for the couples. So earlier you detect and treat is better is the outcome. Parental education and ruling out unrealistic expectation. As I said, it's not the replacement for MDT. It's not the magic drug which will fix the problem. It still has other things going on. There's no substitute for MDT, which is an ongoing phenomenon. And of course, long-term follow-up is needed for these children. As I said, we need a big team to support these children. And unfortunately, I'm blessed to have my colleagues with me. So just acknowledging them in the talk and thank you very much. Thank you.
Thank you, Vivek. As usual, fabulous talk. We have time for 2 questions. Anyone in the audience? There's a mic in the middle. If you can just pop up to.
Good morning. Thank you for the nice talk. Robert Gillan from Palestine. I'm wondering do you really assay for the presence of antibodies against AAV when you administer the drug?
Yes.
And the second question, do you think that there will be a need for another injection or another treatment? Do you see any sign of decline?
Yeah.
And how do you deal with, again, this antibody problem?
There's a big topic of discussion. We all have been thinking about that. Do we need the second dose? At the moment, the answer is no. But again, as I said, the long-term follow-up studies are going, time will tell. And also, we're interested to see if intrathecal is more effective. What we have seen, and I've been discussing with many of the experts worldwide, in the UK and the other many countries as well. There's a kind of, if you see the graphs which I was showing also, they improve significantly. But of course, the reason being, if the dead motor neurons, I cannot regain, revive them back. So there has to be some kind of plateau after a certain phase. Of course, you improve that, and there is a pattern after that. There is a talk, that's why, there's that limitation of monocyte gene. So whether targeting other thing like SMN2, combining the therapy with other thing like risdiplam, Spinraza, even the research is on the muscles, so targeting the muscle activators. If you just target the muscles, would that combination be better, if you to have that cumulative effect? That's one thing. So as I said, the time will tell. Many of my patients, now what I didn't tell is those who are coming late have already received the Spinraza, and that's why they are stable, that's why, they're coming to us at that age and that way. And many of them are opting, they are having the patient support program for Spinraza and risdiplam. So all my patients with the tracheostomy and all, they come to me and say, can they have that as well? There's no answer to that. I don't say no to them, but hopefully, time will tell whether that combination works. That's one thing. Answer to your AAV9, yes, that's a prerequisite, because if you have antibodies, the AAV9 will not even reach to the target, its target. So yes, it has to be.
Just a short additional question. What is the minimum amount? Do you target all the muscles? No, it's not possible to target all the muscles, or at least to get into all muscles. And
so again, the expression of the gene is not everywhere.
what is the minimum you need? Do we know?
Oh, the dose? Dose is
Not the dose. I mean, how much you need to target cells?
No, I wish you can do that study, targeting different
Vivek will
cells
have to
and catching the expression.
Thank you so
But
much.
we don't know that. So thank you.
I think for the sake of time, we will move on. Thank you so much, everybody.